Boa noite a todos, muito obrigado pela vossa presença. Estamos aqui mais uma vez para dar início à segunda sessão das Prostate Cancer Talks. Hoje sobre carcinoma da próstata resistente à castração não metastático. So it's my pleasure to introduce you to one of my friends, Dr. Klassen, Zach Klassen. Zach Klassen is a young and very promising urologist. I mean, it's already a well-known, world-known urologist. He did his medical school, University of Granada, following his urology residency and Medical College of Georgia in Augusta. So after his residency, he completed 2 years of the Society of Urologic Oncology Fellowship in the Princess Margaret Cancer Center in Toronto. So while in Toronto, he also did a master's in science in clinical epidemiology and healthcare research. Currently, he's practicing in USA, in Georgia Cancer Center, and basically in GU cancers. He's also responsible for, he's the director of clinical urological research. He's also responsible for residency program. And it's for me a pleasure to have you here, Zach. Thank you very much. It's also a pleasure to have here with us Professor Carlos Silva, well-known Portuguese urologist. It's a privilege to have you with us today. A professor of Universidade de Porto, distinguished urologist from Hospital de São João. We also have Ricardo Fernandes, urologist, oncologist, medical oncologist. So this is a subject that we need, medical oncologists. It's a very, very good to have you here with us. So Ricardo is a medical oncologist at also University of Minho and Hospital de Braga. So thank you very much. So Zach, so the floor is yours. Thank you very much.
Ricardo, thank you for the kind introduction. Professor Fernandez and Silva, thank you for moderating the session. As I said offline before we started, I wish I was in Portugal, but this is it's great to be with you guys this evening. We're just hitting 4 o'clock on the East Coast here in the US, so I know it's getting late for you guys. So thank you for attending, and I look forward to the presentation and the discussion to follow. So I do not have any relevant disclosures for this presentation. I am a correspondent for Euro Today, which is an online website which covers a lot of the ASCO and ESMO meetings. And so this is sort of where I got interested in this and where I've been able to keep up with a lot of the trials over the last several years that we'll talk about today. So this is, before I get going, this is a young Professor Leao, the most famous one in this picture, in the circled here, right? You can see he's in the back of this picture. This is at the EAU meeting in London. Some of other colleagues you may recognize, Professor Zalata, Professor Fleshner, and then my other two fellows, Thiru Chandrasekhar and Hanan Goldberg. So Ricardo and I met at in fellowship. We were co-fellows for, I think, 1 year before Ricardo finishes his research work and went back to Portugal. So it's a pleasure to have this invite from him to have this discussion today. So in terms of the outline, we'll talk about what actually is non-metastatic castrate-resistant prostate cancer. We'll talk about metastasis-free survival as a valid endpoint for these trials. And then certainly we'll go over the landmark second-generation anti-androgen trials that led to the FDA and the EMA approval. And then recently, as of within the last several months, we've had overall survival data for these trials. And then we'll discuss how do we pick the right agent for these patients. And then briefly at the end, I'll talk about what I'm calling the shrinking non-metastatic castrate-resistant prostate cancer disease space. So before I get into the talk, I just give a little background of where I am. I'm in Georgia, which is in the southeast of the US, in Augusta, Georgia. More famous is Atlanta, which is directly 2 hours and 20 minutes straight west of where I am here in Augusta. We border South Carolina and really have a beautiful coastal region here. In terms of Charleston in South Carolina, as well as Savannah. Beautiful places to visit year-round with great beaches and restaurants and whatnot. So this is where I currently am sitting. If there's any golf fans in the audience, this is also the home of the Masters, which puts us on the map one time a year, typically in April for the Masters tournament. But as you may know, next month we will be holding the first Fall Masters, November 12th to 15th. And unfortunately, no spectators, but we'll look forward to the tournament nonetheless. So without further introduction, so what exactly is non-metastatic castrate-resistant prostate cancer? So this is an increase in the serum PSA despite having a castrate level of testosterone. And so the Prostate Cancer Working Group consensus for PSA progression is the most widely accepted definition of this. It's either 25% PSA increase from nadir, starting at a PSA of 1 or greater nanograms per milliliter, or it's a minimum rise of 2 nanograms per milliliter in the setting of castrate testosterone, defined as less than 50 nanograms per deciliter. So PSA starting, patients starting ADT after local treatment, so radiation therapy, radical prostatectomy, CRPC, typically is before the visualization of metastasis, and this is truly non-metastatic castration-resistant prostate cancer. Conventionally, we've imaged these patients with a technetium bone scan, a CT of the thorax, abdomen, and pelvis, and once these two studies are negative, they are deemed non-metastatic castration-resistant prostate cancer. For these patients, really the goal of treatment is to delay the metastasis and the morbidity associated with the metastases. So what about metastasis-free survival as an endpoint? So all three of the trials we're going to discuss, the primary outcome was metastasis-free survival. So where did this come from? So the ICECAP working group several years ago now in the Journal of Clinical Oncology looked at independent patient level data that they collected from 28 trials with almost 29,000 patients. And they evaluated the surrogacy of metastasis-free survival and disease-specific survival for overall survival. In this cohort of patients, the median follow-up was 10 years with a range of less than 0.1 years to 22.7 years. And you can see that in this follow-up period, 45% of the men had DFS event and a metastasis-free survival event. So long-term follow-up with a decent amount of events in this cohort. You can see in these Kaplan-Meier graphs, on the left, we have disease-free survival in the yellow curve, overall survival in the dotted blue curve. And on the right, we have metastasis-free survival and the overall survival curve. And you can see from these curves that MFS and OS line up very well. And the Kendall's tau correlation for this was 0.91 for metastasis-free survival and overall survival, whereas it was pretty good for disease-specific survival at a Kendall's tau correlation of 0.85. So they did a bunch of fancy statistics, and essentially based on this, they deemed that metastasis-free survival was a good surrogate for overall survival. And when we're talking about prostate cancer, because the disease is, all intents and purposes, relatively slow to get endpoints, finding surrogates for trials to allow for quicker accumulation of events and follow-up being shorter for these trials, maybe taking it from 10 years to 5 years. This is important to have this correlation. So let's move on to talk about the landmark second-generation anti-androgen trials leading to the approval both at the FDA and EMA level. So second-generation anti-androgens, in terms of the mechanism, these are very specific anti-androgen or androgen receptor binders. And you can see here enzalutamide, apalutamide, and darolutamide. And so the specificity of these is really what makes them effective. The first trial that we'll talk about is the famous SPARTAN trial that looked at apalutamide. This was a phase 3 placebo-controlled randomized international study. Patients were eligible if they had non-metastatic castrate-resistant prostate cancer, pelvic nodes less than 2 centimeters below the iliac bifurcation, and a PSA doubling time of less than or equal to 10 months. They had to be on continuous ADT to be eligible for the trial, and then they stratified the randomization by PSA doubling time greater than or less than 6 months, bone-sparing agents, yes or no, and patients that were N0 or N1. And you can see here that they had 1,207 patients. They randomized 2-to-1 to either apalutamide plus ADT or placebo plus ADT with a primary endpoint of metastasis-free survival. And then subsequently, they had several secondary endpoints, including second progression-free survival. So this study was published 2 years ago in the New England Journal of Medicine. with the primary endpoint reached of metastasis-free survival. You can see here on this Kaplan-Meier curve, apalutamide is on the top, placebo is on the bottom. Not just a distinct spread of the curves, but an early spread of these curves with a hazard ratio favoring apalutamide of 0.28, 95% confidence interval of 0.23 to 0.35. So very significantly positive, favoring the apalutamide patients. When we look at the subgroup analyses, this is apalutamide on the left and favoring placebo on the right. And basically, other than patients that were African American or Black, this all favored the apalutamide patients. So we're talking about younger patients, we're talking about all regions of the world, we're talking about number of previous hormone therapies, patients with excellent or decent performance status, ECOG 0 or 1, patients with slow and fast doubling times, and patients that were on bone-sparing agents and not on bone-sparing agents. So if you look at this curve just from an overall global perspective, these basically all the subgroups they looked at essentially favored the apalutamide group with the metastasis-free survival endpoint. In terms of exploratory endpoints, once again, almost essentially a clean sweep for the apalutamide patients. You can see here median time to metastasis, 40 months versus 16 months in the placebo group. Similar results for median progression-free survival. Several of the exploratory endpoints, such as median second progression-free survival, not even reached in the apalutamide group, 39 months in the placebo group with a significant hazard ratio. Median time to PSA progression not reached in apalutamide group, and 3.7 months in the placebo group. And so any way you spun this data and looking at subgroups and secondary endpoints, exploratory endpoints, it was statistically significant favoring apalutamide versus ADT alone. The second trial we'll talk about is the PROSPER trial, which looked at enzalutamide in this cohort. Eligibility criteria for these patients, similar to the SPARTAN trial, slightly different, which we'll talk about in subsequent slides. The criteria for these patients was rising PSA despite castrate levels of testosterone, a baseline PSA greater than or equal to 2, and a PSA doubling time of less than 10 months. And these patients, similar to SPARTAN, were stratified based on PSA doubling time and the use of bone targeting agents. Once again, we see here that the primary endpoint was metastasis-free survival, and a similar randomization of 2-to-1 for enzalutamide plus ADT or placebo plus ADT. You can see here the secondary endpoints: overall survival, time to PSA progression, safety, PSA response, and quality of life. This paper, once again, was published in the New England Journal, same year as the SPARTAN trial in 2018. And basically, it looks like a mirror image to the apalutamide group. Early splitting of the curves, very significant splitting of these curves, enzalutamide on the top and placebo on the bottom, with a hazard ratio of 0.29 and a significant confidence interval of 0.24 to 0.35. So you could almost mirror these on top of each other, and they're almost exactly the same whether you were giving apalutamide or enzalutamide. Very similar forest plot here, looking at the subgroups for metastasis-free survival. Essentially, every single one of these subgroups that they looked at favored enzalutamide versus the placebo. And so some of these were similar. They didn't look at race in this one, interestingly, but geographical regions, PSA doubling time, performance status, all significantly favored the enzalutamide versus the placebo group. Looking at the secondary endpoints, median time to progression, 37 months for enzalutamide versus 3.9 for the placebo group, with a very significant hazard ratio here. Looking at the use of subsequent anti-neoplastic therapy, the median time to first use of therapy was 39.6 months for enzalutamide versus 17.7 for placebo. Once again, a very significant hazard ratio of 0.21. And I'll skip over overall survival because we're going to talk about that subsequently, but you looked at the quality of life, very similar. And when you're talking about similar quality of life, it's important because these patients either were continuing ADT alone or they were adding enzalutamide to ADT. So to have a similar quality of life is important for these patients. The final study that we'll talk about is the ARAMIS trial looking at darolutamide. And not to sound redundant, but a very similar cohort. Men were included if they have non-metastatic CRPC, PSA doubling time less than 10 months. Very similar stratification, PSA doubling time and use of osteoclast-targeted therapy. These patients were also randomized 2-to-1 to either darolutamide plus ADT or placebo plus ADT, with a similar primary analysis of metastasis-free survival. So this study was the third one to be published, once again hitting in the New England Journal of Medicine in 2019. And you can see here, once again, a very significant split of these metastasis-free survival Kaplan-Meier curves, with darolutamide on the top curve, placebo on the bottom, a hazard ratio of 0.41 favoring darolutamide, and a 95% confidence interval of 0.34 to 0.50. Looking at their forest plot for metastasis-free survival, looking at subgroups, very similar to the SPARTAN trial, where the majority of these patients did have a benefit of darolutamide compared to just continuing with ADT. We see that in the other category here, probably including the Black patients, they didn't explicitly state it, that there was no benefit for darolutamide, as well as patients that were Hispanic or Latino. But other than those patients, once again, with very similar stratification and subgroup analyses, majority of these patients favored darolutamide versus placebo alone. Looking at their secondary and exploratory endpoints, you can see here that time to pain progression, as well as time to cytotoxic chemotherapy, time to symptomatic skeletal event, all favoring the darolutamide group. And on their exploratory endpoints, PFS, time to PSA progression, and time to first prostate cancer related invasive procedure and anti-neoplastic therapy, all favoring the darolutamide group. So this is basically a summary of when these agents were approved by the FDA. First was apalutamide shortly after their publication in February of 2018, followed shortly thereafter by enzalutamide in July of 2018, and subsequently darolutamide in July of 2019. So all these trials, very significant for MFS, all published in the New England Journal, all subsequently receiving approval. So what about the overall survival data? We talked about metastasis-free survival being a surrogate for overall survival, but the purists in the room may say, well, is it going to eventually impact overall survival? Because that is the gold standard outcome for these patients. So we had an onslaught of data starting at the end of last year. Interestingly, the SPARTAN group, which was apalutamide, in their second interim analysis reported on overall survival. And you can see here that the hazard ratio was 0.75 favoring apalutamide, but in their statistical plan, they didn't quite have a significant p-value. So it was very close to being statistically significant, but was not yet at that point in time. And this was published in the Annals of Oncology in 2019. They subsequently just recently published a final analysis for overall survival in European Urology about 6 weeks ago. And at this point in time, their hazard ratio was 0.78. And based on their statistical plan, this was statistically significant, with a median overall survival of 73.9 months for apalutamide and 59.9 months for the placebo. So looking at the overall survival subgroup analyses, not quite as clean as the metastasis-free survival. You see several of these subgroups did not favor apalutamide. Once again, we see that the Black patients did not have a benefit, as did the Asians. We see for some reason in Europe, you guys had great patients and they all had a survival benefit versus North America and the rest of the world. And subsequently, we get into some very close hazard ratios here, almost crossing 1. So metastasis-free survival, all the subgroups essentially benefited, where when we get into the overall survival subgroups, not quite as much of a benefit. Prosper eventually published their overall survival data earlier this year in the New England Journal, and we can see here that they hit on their analysis overall survival benefit for enzalutamide versus placebo. Median overall survival for enzalutamide was 67 months versus 56.3, with a hazard ratio of 0.73 and a 95% confidence interval of 0.61 to 0.89. Looking at their subgroup analysis, kind of similar to the apalutamide group, where a majority of patients did have a survival benefit, but once again, we did see a little less of a benefit looking at OS versus MFS, particularly once again in regions outside of Europe, as well as patients with a longer doubling time and patients that were using bone targeting therapy. Finally, darolutamide also published their overall survival data in New England Journal earlier this year as well. And we did see a survival benefit that was statistically significant for darolutamide. You can see on this Kaplan-Meier curve a hazard ratio of 0.69, favoring darolutamide with a 95% confidence interval of 0.53 to 0.88. A very similar looking forest plot for them as well. A lot of benefit for darolutamide. We see no benefit for darolutamide patients less than 65 years, as well as patients that were in Asia Pacific region, and not surprisingly, Asian patients based on that forest plot as well. So not as impressive as MFS, but certainly benefit for a majority of subgroups in the overall survival forest plots. So the question then becomes, we've got all this great data, we've had several publications, MFS, OS, benefits. How do we choose the right agent for these patients? So let's look a little bit closer and compare these trials in more detail. So you can see here that these trials all had a good number of patients. These were all phase 3 trials. You can see here that if from a pure comparison standpoint, there was slightly different inclusion criteria for these patients. So the PROSPER patients did not allow anybody with N-positive disease, whereas the SPARTAN and ARAMIS trial allowed patients with N0 to N1 or N-positive less than 2 centimeters below the aortic bifurcation. We can see here that the PSA doubling time all was consistent between these trials, less than 10 months. And patients in the PROSPER and ARAMIS group had to have a starting PSA of greater than 2, whereas in SPARTAN you did not have to have that. As we mentioned when we were talking about the trial design, they were all 2-to-1 randomized to intervention versus control. As we discussed already, the metastasis-free survival was the primary outcome for all of these patients. And you can see here similar secondary endpoints, notably overall survival for all of these 3 trials. What about the breakdown in demographics? So very consistent for what you'd expect for this prostate cancer population. Median ages of all of these were in the mid-70s. Interestingly, there was no reported racial breakdown for PROSPER and ARAMIS, whereas SPARTAN did a good job of this in terms of white, Asian, Black. And you can see here, I think this is important when we talk about comorbidities of these patients. So the darolutamide group had a lower ECOG 0 at 69% of the patients versus 81 and 77. So a little sicker population in the darolutamide group, which corresponds to slightly higher ECOG 1 percentages of these patients in the ARAMIS versus the PROSPER and SPARTAN trials. We looked at the median time to diagnosis. This is all based on the MFS primary analysis. You can see that the median time to diagnosis was relatively similar between the 2 trials that reported this data. PROSPER did not. Interestingly, the PSA was higher in the enzalutamide trial versus the apalutamide and the darolutamide trials. And we can see here relatively comparable PSA doubling percentages, less than 6 months for 71% in SPARTAN, 77% in PROSPER, and 69% in ARAMIS. So if you looked at these from an overall global standpoint, they look like very comparable trials, but there's a few nuances to some of these trials and how we may select these agents. Finally, you can look here that as I mentioned before, the PROSPER trial did not allow any lymph node metastasis, whereas apalutamide in SPARTAN had 16% and 21% in ARAMIS. And bone targeted therapy was sparsely used in all of these trials. Median follow-up at the time of the metastasis-free survival publication was very similar between these 3 groups. At duration of treatment was a little bit longer in the PROSPER trial versus the ARAMIS and the SPARTAN trial. And when you see here, this is summarizing their primary outcome, very comparable between SPARTAN and PROSPER, and slightly worse for the ARAMIS group at the time of their primary publications. Looking at some of these other endpoints, time to PSA progression was not reached in the apalutamide group and was 37 months for enzalutamide and 33.2 months for darolutamide, but all of these had very significant hazard ratios favoring the intervention group. PFS and time to symptomatic pain progression was not reported in PROSPER, but was reported in SPARTAN and ARAMIS, and you can see here a comparable PFS for SPARTAN and ARAMIS, and slightly worse, but still significant for the Aramis versus the SPARTAN trial in terms of time to pain progression. In terms of time to subsequent therapy, not reported for the SPARTAN trial, a median of 39 months and not reached for Aramis. Once again, still significant hazard ratios, and time to cytotoxic chemotherapy not reported in PROSPER, and very similar between the SPARTAN and Aramis trials, as you can see here, with a hazard ratio of 0.44 and 0.43. So what about OS? So when they initially published their metastasis-free survival data, we can see here that these trials did not have mature enough data for OS when they published their initial publications. SPARTAN has a ratio of 0.70, not statistically significant. PROSPER has a ratio of 0.80, not statistically significant, as well as Aramis 0.71. On the 95% confidence interval, it was, but on the pre-specified p-value for significance, it was not. When we come down here to their most recent publications, you can see here that the hazard ratio for darolutamide was significant. They were all significant, but it was lower for the Aramis group compared to the PROSPER and the SPARTAN trial at 0.69. In terms of safety, this is important because this is one of the factors we may choose to base our decision on who to treat with what agent. You can see here that any adverse events was lowest in the darolutamide group, and this is despite having a theoretically sicker patient population with less ECOG 0 and more ECOG 1 patients. We look at any grade 3 to 4 adverse events, 24% versus 31 and 45.1. In terms of serious adverse events, actually quite similar between these groups at about 25% each. And looking at grade 5 adverse events, this is where darolutamide has slightly higher percentage of grade 5 adverse events at 3.9% versus, 3% for enzalutamide and 1.2% for apalutamide. So still, how do we choose the right agents? There's no head-to-head trials, and this is important. This was all intervention versus control, which is standard of care ADT. So I'll take a minute to discuss a clinical case. I'll introduce it at this point, and we'll talk a little bit further about it as we go in the presentation. This is a patient of mine that I see at one of my rural satellite clinics. This is a 73-year-old African-American male. He had a prostatectomy in 2009 for Gleason 4+4 disease. He then had a biochemical recurrence and had salvage radiotherapy with a short duration of ADT in 2011. And then around 2014, his PSA was slowly increasing. It got up to 0.8. His imaging at that point was negative, and he was started on continuous ADT. In terms of important additional history, a typical 73-year-old coronary artery disease, COPD, hypertension, not the greatest performance status, ECOG 2, and so he may not have been even included in a clinical trial based on his performance status, and which is not uncommon in America in the rural setting is poor family support. He's got Medicare insurance, but he doesn't have a great drug plan. So these sort of things in the real world may make a difference in terms of what they can receive. If you look at his PSA trend, I picked him up when I started practice in 2018, and this is his PSA trend from 2015 to 2019. He's on continuous ADT at this point in time, and you can see the PSA slowly going up to where it got to 2.05, which is when I took over his care and said, this doesn't look right. We'll get imaging, which was negative, CT and bone scan. And then at this point, he's got 3 options. We've talked about these trials. Do you start him on apalutamide? Do you start him on darolutamide? Do you start him on enzalutamide? So we'll come back to that case shortly, but I want to introduce a little more of a statistical nuanced way to maybe select how we choose an agent for these patients. So this is something called network meta-analysis, and this was sort of the paper that got this statistical plan on the ground. And then subsequently, with one of my close colleagues and friends, Chris Wallace, who is currently a surgical oncology fellow at Vanderbilt University in Nashville, a brilliant academic mind. He was a resident in Toronto when Ricardo and I were fellows there, did his PhD in clinical epidemiology, and really somebody who, I mean, he runs laps around all of us in terms of his methodology and how he thinks about things. So he found this paper and he said, I think we should do some of this for for these trials where it's really difficult to figure out which agent is better. And so sort of the framework for how this works is if you have an agent where you're comparing A to B, and you also have an agent where you're comparing A to C, if they've got a common comparator, in this case, the control arm for these trials, you can make a inference as to how these two would interact between B and C because they have a common control arm. And so is this perfect? Is this supplanting, comparative studies? Absolutely not. But in a setting where the disease space is moving quickly and these trials take millions of dollars to work, this at least gives us some food for thought as to how we may select these agents. So we did a network meta-analysis for these 3 trials. This is based off of the MFS data. So with the OS data just coming out, the OS data has not been analyzed in this way. So this is purely based off of the MFS publications. And so what this allows us to do is say, what's the highest likelihood of being the first agent? And you can see here that this is the graph that this analysis gives us. It's a combination of Bayesian and surface area under the curve. And based on this fancy statistical analysis, there's a 56% likelihood that apalutamide would give you the best metastasis-free survival benefit, and a 44% likelihood that enzalutamide would give you the best benefit. We also did this for progression-free survival. Essentially, it was very similar between apalutamide and enzalutamide at 50% likely to give you the greatest PFS benefit. And in terms of this is the premature overall survival data, apalutamide 44% likely to give you the greatest OS benefit, whereas darolutamide gave you 40% likelihood. It'd be interesting to do this now with the updated analysis looking at overall survival. In terms of adverse events, now this is one that we're really interested in because if you're getting a very comparable efficacy with all 3 of these agents, when we look at adverse events, what do we find? 61% likelihood that darolutamide would be the preferred agent based on the side effects and the adverse events in these trials, and 50% likelihood that apalutamide would give you the least preferred agent. So I think when you're dealing with these patients, especially with comorbidities, I think this is probably one of the more important things to consider is what's the adverse event profile and how are we going to counsel these patients appropriately. Dr. Beer at the ASCO 2020 discussion session introduced the DARO-ACT trial, which is actually looking head-to-head between darolutamide and enzalutamide. So we'll actually have comparable data where they're looking at physical and cognitive functional outcomes. And you can see here that this may give us a little bit of better evidence as to between these 2 agents, which one is preferable, at least from a side effect profile. So we'll be staying tuned to see the results of this trial. So going back to the clinical case, as I mentioned, there's a 73-year-old African-American male diagnosed with non-metastatic castrate-resistant prostate cancer. As I mentioned, he's an ECOG too. He's got some comorbidities. So based on what we know and the side effect profile, I said, I think we should give him darolutamide. An American problem is that it wasn't covered by his insurance. And so that's when you have phenomenal nurse practitioners and nurses who start calling these companies. And we found that the apalutamide program has a great charity program, and he's getting this medication at a reasonable cost. And so by default, I chose apalutamide because it was accessible. And unfortunately, that's sort of the nature of how things work in the United States at times. So he's done very well on apalutamide. I started him in July of 2019. He's tolerated well. You can see his PSA trend here. I checked it last in September of 2020, and it's still undetectable. So I think it's, at least in parts of the country where these factors are unfortunately part of the discussion, I think we find a good program, and I've subsequently put 3 more guys on this on apalutamide just based on the fact that they have the best program for folks that can't pay for the medication. So I want to talk briefly about what I'm calling the shrinking nmCRPC space. So there's other imaging modalities that have come about that we all know about. The criteria for entrance into these trials was a negative bone scan and a negative CT scan. But there's also choline PET, there's fluciclovine, Axamin PET scan, PSMA PET scan, which is much more widely available in Europe and Australia than it is in the United States, and certainly whole body MRI as well. So our patients stage with the traditional bone and CT scan deemed non-metastatic CRPC. Are they truly M0? We don't know. Maybe they are, maybe they aren't. Is it unlikely with improved imaging? Probably. Does it really matter? I mean, we don't know. If they're micrometastatic, which they probably are, does it matter if we treat them or not? So there's been several studies that have looked at sort of what the PSA threshold is for these patients and when they're positive. So this was a study published in the Lancet Oncology last year out of UCLA. They looked at 50 patients comparing Axumin fluciclovine PET versus PSMA PET. And these patients had a PSA of 0.2 to 2 after radical prostatectomy. And the primary outcome was detection rate of biochemical recurrence and the anatomical location. Relatively short follow-up, but really they wanted to see how sensitive these studies were to detecting biochemical recurrence at relatively low PSA levels. You can see here in this graph, PSMA significantly outperformed Axumin PET scan, and they have 56% of these patients, remember 0.2 to 2.0 PSA, were detected to have a biochemical recurrence based on PSMA PET. The Axumin PET scan worked a little bit better for the prostate bed, but certainly in terms of lymph node detection, M1A, M1B, M1C metastases, PSMA PET scan outperformed Axumin PET scan. This is a meta-analysis from our colleagues in Australia, another U of T alumni, Nathan Lawrence-Trek and Declan Murphy. This is an updated analysis. They did one previously. And so this is looking at 37 articles, almost 5,000 patients, and just looking at the ability of PSMA PET scan to detect positivity based on the PSA thresholds. And you can see here, even at a PSA of less than 0.19, 33% positive scans, all the way up to 95% positive scans at a PSA more than 2. So if we flip back to our entrance criteria for these trials that we talked about, SPARTAN, Aramis, and Prosper, the median PSA for these patients, 9, 9.7, 11.1, 10.2, 7.8, 8.0, all significantly higher than this median PSA of 2. When we flip back to the Lawrence-Trek meta-analysis, 95% of these patients had a positive PSMA at a PSA greater than 2. So would all these patients have a positive PSMA PET? Probably. So with new imaging, this is a shrinking space. I mean, micrometastatic disease will be detected in probably 95 to 100% of these patients. So this is food for thought, because the Z space is potentially artificial based on our poor imaging that we included in the entrance for these trials, which is much different than what is being used in clinical practice in a lot of parts of the world. So in conclusion, we now have 3 FDA and EMA approved second-generation antiandrogens, apalutamide, enzalutamide, darolutamide for men with non-metastatic castration-resistant prostate cancer. And as I showed you, all 3 of these landmark trials had an MFS huge benefit compared to the control arm. Our recent overall survival data, which was published over the last 12 months, shows a 22 to 31% decreased risk of death for the second-generation antiandrogen treatment versus the control group. And really, the choice of treatment comes down to shared decision-making with the patients, which may be based on the adverse event profile, the drug availability, insurance coverage, etc. And so the impact of the shrinking space with improved imaging on treatment and sequencing of treatment really remains to be seen, and that's where I think the next several years will take us. Thank you very much for your attention. This is our Georgia Cancer Center. This is the outpatient clinical building here. We've recently expanded the research facility with a connection between the clinical side and the research side. I truly appreciate your attention and the opportunity to present to you guys this evening. Thank you.
Good evening. Great talk. Congratulations. First of all, I'd like to greet everyone, and particularly the speaker, Professor Zach Klassen, the other moderator with me, Dr. Ricardo Fernandes, and finally, Professor Ricardo Leao, who is the organizer of these scientific sessions. Given the fact that we have one question, I think you should give them priority. Are you able to see it, the question?
Yes.
From Gonçalo Silva. Exposing the patient to a second generation antiandrogen decreases effectiveness of its use when the patient is metastatic. What about the PFS2?
Yeah, that's a great question. I think, this is getting to the sequencing of when these patients receive these agents. If you look at enzalutamide, approved in the hormone sensitive metastatic setting, non-metastatic CRPC setting, obviously in metastatic CRPC. So I think these are all things that are going to be played out over the next couple of years. And the sequencing is really the next sort of hurdle to overcome. Professor Fernandez, you have in medical oncology world, what are your thoughts on this?
Sorry, I didn't understand.
As a medical oncologist, it's the sequencing and the effectiveness in subsequent lines of therapy and disease states.
Yeah, it's one of our major concerns because we in this particular setting we don't have enough data to. It's an early results. So, but in a metastatic setting, yes, we on our daily practice we see the changes that we make on the patient. Of course, we have to take into account what we give in the first line setting of second generation hormone therapy, what impact will have on the subsequent therapies. So we must give the most effective one. But in the metastatic setting, we give either abiraterone or enzalutamide. So the results show that it is not that much difference between them. But in the non-metastatic setting, we don't have enough data to make an option. So.
Okay, there are no more questions from the audience. I have a question for you concerning this particular setting of disease. This phase of advanced prostate cancer. How many patients do you see per year on average in your practice?
It's a good question. When Professor Leao can attest that in Toronto, the urologists see a lot of these patients. I mean, for instance, Neil Fleshner has almost a complete clinic of advanced prostate cancer. And so, at least in my opinion of fellowship, Ricardo, you can back me up, I think unless they're giving chemotherapy, they will see a lot of these patients and treat them. In the US, I probably have significantly less than that. I find that I'm comfortable giving these in the clinic. Probably 10 to 15% of my patients, prostate cancer patients, are in sort of this hormone sensitive, non-metastatic CRPC. I think that the sort of the politics of how things work, I work very closely with my medical oncology colleagues as well, and I'll often get them to weigh in on what their thoughts are. I would say that we have a preference of giving chemotherapy up front here. Perhaps that's partial to the cost, and certainly when I get to the point where they either need docetaxel, cabazitaxel, or radium, our medical oncologists are doing all of that.
Okay, you said that you see about 15 patients per year?
15% of my prostate cancer.
Okay.
So that's probably, I'd say it's probably 20 to 25 are in that setting.
Okay. There is another question from Ricardo Leao. Is the safety profile the best variable to choose drug?
Yeah, I think it's when you've got very close efficacy, which I think if you delve into the details of these trials, there's some differences, but generally the efficacy is very good for all of these. I think it makes a big difference. I think how these patients tolerate the medication is a huge quality of life factor. They're already somewhat, quality of life depleted based on the continuous hormone therapy. So adding that subsequent agent, I think, quality of life is a big deal for these folks.
Okay. Actually, we are dealing with patients who generally are asymptomatic. They have no symptoms.
Right.
So side effects are important in this setting. In your practice, if you have to choose, I realize that you choose according the first factor was comorbidities, and in that case, you'd go to darolutamide. But do you have any trick, any factors that trigger your decision?
I think primarily, I do believe that if you look at the inclusion criteria with darolutamide being sicker patients and generally well tolerated, and if you believe the network meta-analysis, with some people have vehemently come against us in how we analyze this data, I still think that the darolutamide is probably the best tolerated. I think my personal practice is too small to compare head to head, but I think the ability to not cross the blood-brain barrier, some of these more comorbid patients, I think darolutamide is better tolerated in general.
Okay. Ricardo Leao has another question, but he asked, should you start chemo instead of second generation hormone therapy for Afro-American patients? But I want him to clarify, because chemo is not approved for this phase of disease. Why should chemo?
That's true. So the question is, and I think I think we discussed this before about African American patients. What we can see is for these patients, we don't take them. They clearly respond different to this treatment. My question is, are these patients from the beginning? Of course, we understand they have a different biology, but from the beginning, should we test them differently? I mean, in terms of imaging, my point is, if they progress with these agents and the others who don't progress, should we? Of course, chemo is kind of provocative, of course, but again, we do chemo as neoadjuvant treatment, high risk prostate cancer. So the question is, should we give something for patients that from the beginning? Of course, this links to something about biology that we can talk about, but my point is, should we screen these patients differently?
It's a great question, Ricardo. I would say that probably 60% of my prostate cancer patients are African American, and it's not uncommon on almost a several times a month basis that you get an African American patient presenting with a PSA of 500 and diffusely metastatic disease. And so I know it's not a specific nmCRPC question, but we certainly have those patients still present to our clinics, and our sort of upfront in that setting is docetaxel. But you're right. I mean, if we were to believe that generally most of these patients are probably micrometastatic already, and they're technically mCRPC, docetaxel probably wouldn't be unreasonable either. My medical oncologist tells me that he thinks that getting the chemotherapy in early, they're a little healthier, and they haven't had subsequent lines of therapy. His preference is that, and I can't disagree with that.
Yeah, I personally agree with you. Yeah. On my daily practice, I use the same rationale. So if the patient has an ECOG of 0, and most of them, the younger the better. So hit them with chemo first. So Professor Klassen, regarding the economic toxicity profile of both of the three agents, what are your major concerns?
My major concerns are that if you have somebody who is a well-insured patient, there really is no financial toxicity because their plan will cover that. I work in a tertiary state hospital, and so we do see well-insured patients from the community that need the cancer center tertiary care, and those patients we can generally pick whatever we want. But a lot of the patients are the patients that I described in the case where they're economically challenged and financial toxicity is real, and they literally have no ability to pay for the medication out of pocket. So I've found that the Janssen folks with apalutamide have been by far the easiest to get these charity programs. Very difficult with enzalutamide and quite difficult with darolutamide. So in clinical practice, I guess it makes my decision a little bit easier because that's one of the driving factors as well, is can the patient actually get the medication and continue to get the medication. So I mean, financial toxicity is real in the U.S. Professor David Benson at Vanderbilt, the chair of urology there, gave a phenomenal financial toxicity talk at GUASCO this past February, which seems amazing that we were actually in person for that meeting, given everything that's happened since February. But it blew away a lot of the international audience because of how real that aspect is.
I think we have another question from the audience, from Antonio Quintela. If we don't use the best diagnostic tests like PSMA or other, do we miss oligometastatic disease? Is this relevant in this setting?
Yeah, that's a great point. I mean, there's a lot of data coming out, the Sabre Comet trial, and then subsequently the STOMP trial with Pete Ost in terms of SBRT for treating these patients with oligometastatic disease. And there was a great talk at the SIU meeting virtual a couple of weeks ago, and it was debating systemic therapy versus targeted therapy with SBRT or surgery. And the point was well made. I mean, we have phase 2 trials for targeted therapy in the oligometastatic setting. We're awaiting phase 3 trials, and I think that will probably be where we see the shift if those trials are positive. But I think to answer the question, I think it probably is relevant in this setting. It's just the data probably isn't quite there yet.
Okay. You are a urologist like me.
Yes.
But in fact, you are younger than me. And I have a question for you. What is your opinion about the endocrine manipulations like retiring the first generation antiandrogen or secondary hormone therapies, the ketoconazole, or even the dexamethasone in this setting?
Yeah,
what's your opinion about that?
So you may be surprised, or you may not be surprised, that I probably use ketoconazole 3 to 4 times a year. And the reason being is we still see the patients that come in with spinal cord compression. They're in the hospital, and it's easy to get ketoconazole and give them the prednisone with it, and they can stay on that for. I mean, I've actually had 2 patients in the last 6 weeks that I put on ketoconazole. So I probably practice in a bit more of an old school setting versus maybe some of the ivory tower places in New York and whatnot. But I think in the right setting, I mean, ketoconazole, prednisone, I mean, that'll shut down the testosterone within hours, as you know. So.
Okay, I have another question for you. You have a patient with a biochemical recurrence after radical prostatectomy and the salvage radiotherapy, and you are not able to demonstrate to view the lesions, the metastatic lesions. When do you start hormonotherapy? What is your trigger point?
That's a good question. Professor Leao will probably ascribe this as well. With we both were with Lori Klotz in fellowship, and his threshold was very high. I mean, I can't remember. It was probably 8 to 10. He would just watch these patients, and then he would start therapy. And he's a huge fan of intermittent ADT as well. And so I kind of ascribe to that as well. Maybe not quite. I don't wait quite as long. I usually wait till it's about 2 to 3 before I'll start giving ADT. And we don't have access to. We have Axeman PET scan at our hospital, but we don't have PSMA PET scan. So I find that that 2 to 3 range for my patients is where I kind of go with.
Okay, because today, even this morning, I saw a patient with a biochemical recurrence, and his PSA level was 18.
Yeah.
And the PSMA PET was negative.
Yeah.
Was not in page with your data saying that more than 90%. So my decision was to wait and see.
Yeah.
To keep it under surveillance.
And I think the point's well taken. That if you look at there's other literature coming out. One of my other interests is the mental health and prostate cancer patients, and we know that ADT is not a free medication. You know, the dementia, the depression for sure. These are all real side effects. So I think that sweet spot, you know, it may shift, and I think that PSA 3, maybe it should be 5, and maybe Lori Klotz is right, it should be 10.
It's great to decrease the anxiety of patient and the doctor.
That's right, absolutely. That they want to see that number come down.
Yes.
But the cumulative effects of ADT are not benign, for sure.
Professor Klassen, one question. Sorry. We saw that the broader availability and application of PSMA PET will shrink the number of patients being diagnosed as having non-metastatic CRPC. But do you believe that the application of this kind of PET scan in this setting will lead to a change on the treatment decision, translating into a longer survival?
It's a good question. I mean, I think these patients they're getting the therapy at time point 0, whether it's conventional imaging negative or PSMA positive. Interestingly enough, if you think about it, apalutamide is not approved in metastatic CRPC, but you can make the argument that these patients are already early metastatic CRPC. So I don't think it's going to change my management if we start to see an increase in these patients, because I think the data is there, and if we're being transparent, we know these patients are already micrometastatic, and I don't think it's going to change. The OS data is still the OS data, I think, no matter what.
Yeah, very robust. So.
Yep.
Okay. Do you see any role concerning genomic markers in this setting?
Yeah, that's a great question. We know that you're talking about like biopsies and genetic profiling, that sort of thing.
Mm-hmm.
Yeah, I think if you look at, the olaparib story over the last year or so, first presented, I think, at ESMO 2019, and then the OS data published just recently in New England Journal. I think this is going to drive a lot of it, and this is obviously heavily treated nmCRPC patients, and really targeting therapy based on what their genomic profile is. But certainly, I think if we fast forward 5 years and we're having the same discussion, I think a lot of it will be driven by genomics of the tumor, for sure. And I think, you got rucaparib, we got olaparib now. Niraparib probably will be approved at some point in time. So I think it'll be interesting to see how much earlier in the disease process the PARP inhibitors are gonna become. And I think that's probably going to be what drives a lot of this as well.
Okay.
Can I ask you guys a quick question? What percent of your advanced prostate cancers are getting genomic profiling, would you say?
In my clinical practice, just a few.
Yeah.
When we have to decide if you give them the PARP inhibitors.
Yeah.
Just in that case.
Yeah. Professor, yourself.
In my hospital, we are asking for the genomic profiling on the younger patient, but on the metastatic setting. As soon as the diagnosis is made, we ask for the genetic profiling. So it will have an impact. We hope to have the impact on the future therapeutic options. So.
Yeah, it's interesting in that if you look at some of the guidelines, I think it's NCCN that any high risk, even localized disease, should be getting genomic profile. And certainly where we are, we're kind of in line with you guys, where if it's going to make a difference between a PARP inhibitor or not, we'll profile that. But I think it's probably outside of the clinical trial setting. I think the profiling is probably vastly underused in the real world. So,
yeah, I agree.
The question is also, when do you give these patients PARP inhibitors? So, because you don't have data to give PARP inhibitors outside the advanced disease. So I think we should follow these patients differently. That's the point. Also with the introductory biopsy eventually, and not to advise these patients to do active surveillance. So I started a kind of prostate cancer risk clinic or consultation. And what I found is sometimes patients don't really want to do the genetic test. So in private clinic, you have a lot of legal issues. So they have to sign for that. And so it's the insurance companies that are paying. So they are kind of afraid of going for it. So in public care, it's the same. I have the same experience as Ricardo. So we work together. So we usually ask for all patients with young patients, family history, and basically the patients that appear with metastatic disease. So we basically ask for all of them. We didn't change any treatment, I think, as far as I know. But at least we know. And so I can tell you a story. So I have a patient that I met a few years ago. This guy did docetaxel, enzalutamide, like 5 years ago eventually. We were coming from San Francisco, actually. So, and he was about to do PSMA lutetium and was a BRCA patient. So was at KUF actually. We started him on olaparib, and he survived, I think, 3 years, and the PSA decreased from 100 to almost 5, 6. Wow. And he was, so the metastatic burden decreased as well. So, and we also have good results when we know that with PSMA and lutetium, but this is different. And for these patients, I think we should do genetic profile for all of them. This, for private clinic, I think, I don't know if anyone has different opinion. It's kind of difficult sometimes. The patient don't want to.
I think your point's well taken. I think, you know, they're afraid what they're going to find and what the implications may be on their family members, right? I mean, you find a BRCA2 mutation and the rest of the females in the family haven't been tested, you know, what do you do at that point? And so I think that's probably legitimate. That's a legitimate fear, I think.
Just a comment. I enjoyed your expression, shrinking space.
Yeah.
Do you think that we are talking about something that doesn't exist?
I think to a certain extent we are. I mean, I think that the systematic review from Australia showing, you know, at least the sensitivity and specificity of PSMA, and then what you compare to what the median PSA is of these patients coming into the trial, I think you have to be thinking this is somewhat artificial. And a comment was made on Twitter when Ricardo tweeted it, and they said, somebody said, does this space even exist?
Oh, so this was a fiction hour?
I think you know, we have to think about this in a logical sense that it doesn't matter if we treat these patients that are theoretically micrometastatic with these agents. And I think the answer is we still treat them because clearly we have data that it works. And whether we call this non-metastatic CRPC or micrometastatic CRPC, I think that may be just a terminology thing. But these patients are all clearly in that same sort of, you know, close net box and in that disease space, whether terminology is micrometastatic or non-metastatic.
Okay. There is a question from Diogo Costa. Platinum-based therapy in BRCA mutated prostate cancer patients. Do you have experience in your center concerning this therapy in these patients?
That's a good question. I personally don't. My medical oncology colleagues, they may have some experience. As a urologist, I don't give chemotherapy. So to answer the question, I don't have personal experience. And I don't know of a lot of those specific patients.
Yeah. In our hospital, we don't have any patient, BRCA mutated patient, so we don't have that kind of experience.
Okay.
So in your center now, Zach. So Enza, Apa, all these drugs are they prescribed by urologists or in a multi-D clinic or just by medical oncologists?
Good question. So there's three urologic oncologists in our center, including myself. I would say that I prescribe the vast majority. My partners maybe not so much. So to answer your question, most of it is by the medical oncologist. However, I do, based on just my experience that we had in Toronto, I feel comfortable managing these patients until they need, you know, chemo or radium at that point. Or immunotherapy as well. So I think majority med onc, my practice is probably skewed a little bit more towards urology. If I see these patients and I know a fair picture of what I think they need and where they're at, they have that chemotherapy, I'm comfortable treating those patients.
Okay. I think there are no more questions.
Ricardo, do you have a question? Okay.
There is another one from last minute question.
Last minute question.
Antonio Quintela. Coming back to the 3 trials, as far as I know, there is no mention about previous use of salvage radiotherapy after surgery, prostatectomy. Is that relevant?
It's a great pickup. I agree with Professor Quintela. I don't think there's any mention of it at all as well. I don't think it's relevant because I think that once they get to their disease state that they're in for clinical trial enrollment, you would argue that what happened previously probably is not as significant. Maybe that's kind of an opinion more than anything. But you're right; it's not mentioned, and I don't think it's necessarily relevant in my opinion.
Okay,
I don't know if you guys have thoughts as well on that.
The question might be also because sometimes for high risk, you use hormones plus radiation. So I don't know if that can change the natural history of the disease based on both treatments together. I agree. It might be the same, but we don't know.
Yeah.
So I don't know if there are more questions.
No more questions.
So if no, I can end the session. I think it was a very good session. Thank you, Professor Carlos Silva. Thank you, Ricardo. And thank you very much, Zach. I think we were talking about 1 year about one disease that does not exist. So probably in a few months we will see that we are right. I think what PSMA will tell us is we can split these patients in 2 groups of patients with low burden metastatic disease, eventually higher burden. And eventually you can go back to these patients and see which ones respond or not. I don't know if I'm correct. It's not a question. I don't know if we can discuss this now, but I think you can. And thank you very, very much. I think we will wait for you in Portugal soon. I think Professor Carlos Silva can invite you soon or something at our Portuguese Association. And it will be a pleasure. So my home is your home, so you don't have to spend money at the hotel.
Thank you.
So thank you very much. And we'll be together soon for another session. Okay, thank you very much. Have a good night.
Thank you very much, Professor Claassen. Excellent talk.
Thank you.
Bye.
Bye.
See you soon.